Hello, and welcome again to the Emergency Medicine Clinics podcast. I'm Colleen Dietzler, the Managing Editor of Emergency Medicine Clinics here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing a recent issue titled Obstetric and Gynecologic Emergencies. Joining us today are the guest editors of this issue, Dr. Joelle Borhart and Dr. Rebecca Babalek. All right, so let's just jump right in and look at our first highlighted article from your issue. This article is called Complications of Assisted Reproductive Technologies by Hilbert and Gunderson. Can you provide some background on assisted reproductive technologies?
Sure. So assisted reproductive technology, which includes in vitro fertilization, has been resulting in live births since the late 1970s and the early 80s. And assisted reproductive technologies are becoming increasingly common and now account for almost 2% of live births in the U.S. And this article by Dr. Hilbert and Dr. Gunderson, I think, is so important because it's one of the only articles I have seen that clearly outlines the assisted reproductive technology process and medications for emergency physicians.
Great. And can you describe some complications that can arise from assisted reproductive technologies and how these complications should be treated?
Sure. So probably the most important complication for emergency physicians to be aware of is ovarian hyperstimulation syndrome. This is essentially increased vascular permeability that can lead to third spacing of fluid and pelvic ascites. And ovarian hyperstimulation syndrome can be mild or moderate or severe, and mild cases are usually managed conservatively as an outpatient with pain control and close follow-up with the patient's OBGYN. But severe cases can put patients at risk for pleural effusions, blood clots, and other complications, and the patients can become quite sick. So it's really important for emergency physicians to engage the patient's obstetrician very early in the ED course if there is any concern for ovarian hyperstimulation syndrome. Other complications from assisted reproductive technologies can include ectopic and heterotopic pregnancies, as well as ovarian torsion. And for these reasons, the authors of the article recommend that all patients that are undergoing assisted reproductive technology who present to the ED with pelvic pain or abdominal distension should have a pelvic ultrasound to evaluate for ovarian enlargement or free fluid.
So what exactly does this technology entail, and what is the standard process?
The CDC defines assisted reproductive technology as any treatment where oocytes and sperm are handled outside of the body for the purpose of establishing a pregnancy. And in general, this process begins with administering medications that stimulate the ovaries, followed by egg retrieval, and then in vitro fertilization, where they combine the egg and the sperm together in a lab, and then transferring the embryos back into the uterus. And this article does an excellent job of describing these steps in detail in a way that I haven't seen done anywhere else. And the authors also advise that using ovarian stimulating medications alone is not technically considered assisted reproductive technology as defined by the CDC, but emergency physicians should approach these patients in the same way, as they are still at risk for many of the same complications as patients undergoing in vitro fertilization.
Great. Okay, so moving on to our second article called Trauma in Pregnancy by Sakamoto, Michaels, Eisfelder, and Joshi. Dr. Babalek, treating a pregnant patient in the emergency department presents unique challenges. Can you describe those challenges?
I think that the patient that presents to your trauma center that's pregnant is a kind of an anxiety-inducing type of scenario for many emergency physicians. So this article does a nice job of summarizing some of the things that you have to keep in mind. One of them, I think the biggest thing is, of course, you're kind of dealing with two patients instead of one. But, taking care of a pregnant patient entails a lot of physiologic changes. They're very sensitive to hypoxia. They have less respiratory reserve in the face of that. And then also other physiologic changes. They have relatively low blood pressure. They have baseline tachycardia, which makes it really kind of hard to assess what their volume status is. And is this a normal change in pregnancy, or actually is your patient presenting in shock? And then I think also just sort of our assessment of trauma patients usually in trauma patients, we use liberal radiologic testing to try to figure out what their traumatic injuries are, and that still holds true in pregnant patients if needed. But I think again, gives any physician sort of pause, because there's a bit higher stakes with radiologic imaging and radiation exposure to a developing fetus. So there are many sort of challenges for the pregnant patient, but those are kind of the highlights that come to mind.
Dr. Babalek, tell us a bit about the risk factors for trauma in pregnancy.
Yes, overall, when we see traumatically injured patients, pregnant patients do account for a small portion of those. So they are relatively rare, but high-risk populations do include patients that are of younger age, less than 26 years old, African American or Hispanic ethnicity, also markers that track with lower socioeconomic status, on Medicaid type insurance, and patients who have had minimal or no prenatal care throughout the course of their pregnancy. The largest kind of cohort of traumatically injured pregnant patients include unintentional trauma, such as motor vehicle accidents or falls. Intentional injuries account for about 15%. But even though it's a very small number, they're very important, because these are patients who are at high risk for intimate partner violence, domestic violence, and so they are victims of assaults or even of self-harm. So remember that pregnant patients are twice as likely as non-pregnant patients to experience violent trauma. So as an emergency physician, kind of have to keep your suspicion up and do screening for patients who may be victims of interpersonal violence.
Okay. And what changes take place in a pregnant patient that can impact treatment?
Of course, when patients are pregnant, it includes many changes all throughout the body, but I think the most important ones are really important to the ABCs of trauma. So in the airway becomes quite edematous, and the tissues in the airway itself can become friable. So you should be prepared for a difficult airway. In addition to that, because of the changes in the cardiopulmonary system, there's increased oxygen consumption by the patient and the fetus, and so there's really decreased reserve. So in addition to being prepared for a difficult airway, also need to be able to establish an airway quickly, because as I mentioned before, these patients are very susceptible to hypoxia, which of course isn't good for the developing fetus. In addition to that, as the uterus grows up out of the pelvis, all the abdominal contents are shifted upward, and so the diaphragm's a bit higher than expected. So if doing a chest tube placement or something like that, need to be aware of the diaphragm. And because of the changes in the abdominal contents, you do have decrease in your venous return. So when a patient's lying supine in later in pregnancy, you get less venous return. So you have to do what's called manual uterine displacement. So have an assistant or somebody at the bedside pushing the uterus up and over to the left in order to maximize that IVC diameter and increasing your venous return. And so on top of all those things, because of all those changes kind of put together, as I mentioned, patients have a baseline tachycardia and lower blood pressure, but they are able to maintain that for a while until they present in fluid shock. And so, again, need to be aggressive with resuscitation. And if it's hemorrhagic shock, of course, need to start treating with blood and O-negative blood if it is available to you.
Okay. So can you describe the trauma evaluation and survey of a pregnant patient?
Well, I think the good news is really that this is in the wheelhouse of any emergency physician. Essentially, the primary survey itself is the same. So proceeding through the A, B, C, D, and E exactly as you would on a non-pregnant patient, but of course keeping those physiologic changes in mind in case you have to intervene on airway, breathing, or circulation. If after the primary survey is done and the patient's stable, you want to kind of try to think about the fetal well-being, of course. We have at our bedside all the time an ultrasound, and so you can assess if there's fetal heart tones, the estimated gestational age, and again, this is after you stabilize mom first, and then you can also perform a FAST exam. And the FAST exam pretty much has the same sensitivity and specificity for intra-abdominal free fluid as it does in the non-pregnant patient. And then as you proceed to the secondary survey again, head-to-toe exam, keeping in mind again that these patients may be victims of interpersonal violence, so looking for signs of abuse and looking all over. And then, of course, adjuncts to the trauma evaluation include imaging, and you should really image as necessary. We want to be mindful of radiologic exposure in all patients, but again, these patients need a full evaluation, and if they're critically injured, need to get the imaging that's necessary, including a CT scan.
Okay, great. How should fetal evaluation and resuscitation be performed?
Yeah, so again, as I mentioned before, the best thing to do, of course, is to stabilize and resuscitate mom. And then after that, because that's the best way to really make sure that the fetus does well. After that, after mom is stabilized, you can assess fetal well-being with ultrasound. Now let's kind of back up and assume this may not be a critically injured patient, but something like a fall. If they're stable, again, these patients are at high risk for things like placental abruption, and so you need to get TOCO monitoring ASAP, and these patients should be on there at least 6 hours if everything is going right. So the fetal distress that you can see on TOCO monitoring is a surrogate sign for fetal hemorrhage, hypoxia, early signs of abruption or uterine rupture, and so these patients really do need to get on monitor sooner rather than later. And that 6 hours of time can extend if there's any abdominal tenderness, if there's bleeding, if mom's having a lot of contractions, if there's non-reassuring fetal heart tones, etc. So really at this point, you need to get these patients involved with your OBGYN colleagues for monitoring.
Okay. And what are some specific maternal injuries?
So patients that are traumatically injured, MVC by far is the most common mechanism of injury. And you can have pretty severe injuries if there's no seatbelt. As you can imagine, a gravid uterus to hitting a steering wheel or a dashboard can cause very severe injury. Airbags, a lot of patients want to know about sort of airbags and seatbelts. Airbags and seatbelts are still recommended for pregnant patients. The airbags really have not been shown to be more likely to cause abruption or fetal loss. But again, abruption is the thing to worry about, even if there's a minor accident. So get those patients on monitoring. Penetrating injuries are relatively rare. So maternal mortality kind of is the same in penetrating injuries as the non-pregnant patient. But there can be quite a bit more morbidity in that setting. And then again, I can't stress it enough, thinking about domestic violence or interpersonal violence, intimate partner violence, more common in pregnancy. Up to 20% of women that are pregnant are victims of intimate partner violence. And these patients are at risk for spontaneous abortion, preterm birth, fetal distress, or even death. They can be very hard to pick up, so you really, really need to screen all of your trauma patients. And then lastly, the last thing to think about kind of is burns. And these patients are essentially treated the same as a non-pregnant patient.
Okay, great insights. So let's move on to our third article topic. This article is titled Late Pregnancy and Postpartum Emergencies. This was by Al-Abdullah, Hartline, and Wheaton. Dr. Bavalek, what is unique about late pregnancy or post-delivery, and what does this mean for the emergency physician?
Yeah, so late in the third trimester and then early in postpartum, there's again still a lot of physiologic changes, and these patients are at risk for many things, and it's a relatively hypercoagulable state. And we'll talk a little bit more about that in a minute, but it's a high-risk time for a lot of different conditions, and many women don't see their obstetrician for up to 6 weeks. So an emergency physician may see many of these patients very early on. And these patients, they're going through a lot. They've just had a baby. There's a lot of sleep deprivation. For those out there who are parents know And these patients can be really overwhelmed and not really know where to go to get support. So as emergency physicians, we are sort of their lifeline and their place to get medical advice and support. And sometimes it can be a simple thing, but sometimes there can be life-threatening conditions that occur during this period.
Okay, so let's go into those conditions a bit. The first condition described in the article is peripartum depression. Can you expand on this type of emergency and how the emergency physicians should approach it?
Yeah, so this is defined as a major depressive episode within 4 weeks of delivery. So before or after, it affects quite a few women. So 10 to 15% of pregnancies, women can develop postpartum or peripartum depression. And they can be difficult to pick up. So sometimes patients come to the emergency department with unrelated complaints or complaints with the infant that are insignificant. And so again, it takes a pretty astute emergency physician to think about this, but it's a screening opportunity to really get some information about how things are going at home. A lot of, the symptoms that you're looking for are very similar to other major depressive disorders, but they can manifest in different ways. So for example, they can come in with a lot of anxiety regarding their concern for the ability to care for the baby, if their baby is okay. Hard to tell because a lot of symptoms of major depressive disorder overlap with things that happen normally when you have a baby. So there's no sleep, you can have low mood. So it's really important to screen everybody, ask very careful questions, get collateral, and if you're worried about it, you should get input from a psychiatrist.
Okay, great. The authors then move on to a section on peripartum cardiomyopathy, or PPCM. What are the risk factors, diagnostic testing, and prognosis for PPCM?
Yeah, so peripartum cardiomyopathy, the cause is really sort of multifactorial and sort of a lot of different things go into it. So the risk factors include advanced maternal age or underlying issues such as preeclampsia or pre-existing hypertension, or patients who are multiparous. It's interesting always as an emergency physician because risk factors are interesting to know, but really this patient will present to you just like normal CHF. And so it's basically congestive heart failure in the setting of a peripartum period. And treatment is similar. So correcting hypoxia, supporting respiratory status as needed, and the medical treatment is very much the same as regular congestive heart failure. They may need counseling regarding future pregnancies once they're stabilized because these patients are at risk for worsening heart failure in subsequent pregnancies.
Okay, and the final section of this article deals with pregnancy headaches and neurological emergencies. What are the specific conditions and treatments the emergency physician needs to be versed in?
Yeah, so headaches can really range from sort of routine all the way to life-threatening, and so it takes a very careful history and physical exam to help you guide your way. So patients who do suffer from migraines, sometimes actually early on in the pregnant period, they have less migraines than they normally do because of hormonal changes, but then afterwards, after delivery, can have increasing migraines. And again, the treatment for those are exactly like the non-pregnant patients. Other things to think about just after delivery, if patients had an epidural, you can actually have a dural puncture headache. And again, it's much like our post-LP type headaches that we see in the emergency department. You use IV fluid, caffeine if it's available, but really the most effective treatment is a blood patch. Complications such as meningitis after getting an epidural is relatively rare, thankfully, but it can present. So you want to take a good history, make sure there's no fever, no neck stiffness, nothing to make you think that this patient may have meningitis. But I think that really the ones to think about are sort of stroke, intracranial hemorrhage, and venous thrombosis, so cerebral venous thrombosis. So these patients are increased risk over the general population for intracranial hemorrhage, and this extends up to 6 weeks postpartum. So risk starts going up in the latter part of the third trimester, and then stays high through the postpartum period up to 6 weeks. So as these patients present, you need to be careful and think about, does this patient have a subarachnoid hemorrhage or some sort of other intracranial hemorrhage, and image as needed. Stroke, thromboembolic stroke can happen in this period because of the fact that it's a hypercoagulable state. And again, these present just like regular stroke, except for the fact that these patients, of course, are much younger than our general stroke population. If they do have ischemic stroke, you can use TPA in these patients. And the last thing that I think we should talk about is sort of central venous thrombosis. It's a really difficult diagnosis to make. They present in various ways. It can look like altered mental status. They can present with seizure. It can mimic an ischemic stroke syndrome. So again, careful history. Time course is a little bit different than an ischemic stroke, but these patients need an MRV to really figure out, do they have a venous thrombosis? And it's a diagnosis to consider if they kind of come in with progressive, daily, worsening headaches. And the treatment of choice for these patients is anticoagulation.
Okay, great. So let's move on to our final article topic. This article is called Cardiovascular Emergencies in Pregnancy, and it's by Borhardt and Palmer. Dr. Borhardt, why are pregnant patients at an increased risk for cardiovascular emergencies?
Well, the physiologic changes of pregnancy place a significant amount of stress on the cardiovascular system. We talked about a few of those physiologic changes earlier on the trauma article, but there's increase in blood volume, increased heart rate, increased cardiac output, all place significant stress on the cardiovascular system, as well as pregnancy being a hypercoagulable state. So that puts the pregnant patients at increased risk for developing blood clots and pulmonary embolism.
And can you describe the specific cardiovascular emergencies that may present in pregnant patients and how the emergency physician should manage and treat these patients?
So pregnant patients can develop the same cardiovascular emergencies as non-pregnant patients, and that includes pulmonary embolism, aortic and coronary artery dissection, acute MI, and heart failure. And it can be really tricky to diagnose these conditions because the signs and symptoms, they overlap with each other, and they also overlap with the physiologic changes in pregnancy. So, for example, most women by the end of their pregnancies feel short of breath and have leg swelling, but those can also be signs and symptoms of heart failure or a pulmonary embolism. So it can be tricky to tease out the diagnosis in this specific population. But in general, the management of these cardiovascular emergencies is the same for pregnant and non-pregnant patients, with the exception of a few medications that should be avoided in pregnancy, such as warfarin, ACE inhibitors, and some diuretics. But the most important thing, I think, for emergency physicians to remember when caring for a critically ill pregnant patient with a cardiovascular emergency is that the maternal well-being takes precedence because the best chance for a good fetal outcome is a good maternal outcome. So not to let the fact that the patient is pregnant distract them from making the diagnosis and giving the patient the treatment that she needs.
Okay, great. Well, that about wraps it up for our articles for today. Before we wrap up, any final thoughts on the issue or topic as a whole?
Yeah, I think that it's a really good collection of articles, good updates in there. Again, these patients present to our emergency department all the time and can present challenges, but I think the good news is many of the things that we're diagnosing and treating are well within sort of the part and parcel of what we do as emergency physicians every day. So I encourage everybody to take a look at the issue and get up to date.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on obstetric and gynecologic emergencies, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access and can be accessed on the Elsevier electronic platforms Clinical Key and Science Direct. For more information, visit info.theclinics.com. Be sure to follow us on Twitter at eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes. Recent issues of Emergency Medicine Clinics have focused on ear, nose, and throat emergencies, infectious disease emergencies, and hematologic and oncologic emergencies.